Hello, my name is Pat Burke. I'm with SurModics. We're at the TED conference in Scottsdale, Arizona. I'm here today to talk to Dr. Lodha about radial and radial procedures in his lab. Hello, Dr. Lodha. How are you doing today?
Good. Thank you.
Can you tell us a little bit about your experience with radial procedures and how it's kind of worked into your practice?
We started doing radial accesses for peripheral procedures somewhere around 2016, 2017. That was the time that companies were coming up with the products that could be used from radial length products that could be used from radial artery, and peripheral interventions could be performed. So our experience has been pretty long. We've been with the growth of this technology, and I feel that it has really supplemented what I can offer my patients. It's safer approach. I would say that it's not for every case. We're still missing some kits, some tools in our toolbox, but I think it is something that I do offer all my patients and consider radial access as their primary access almost in every case.
And when you say about you would like more tools in the toolbox, can you kind of expand on that?
So it is very interesting that you pointed out. When radial access initially came in as an access for peripheral procedures from the experience we have gained from the coronary interventions, we've realized that radial access is far more safer and saves lives when we used our experience from coronary studies. The problem with radial access for peripheral procedures is, unlike in the coronary experience, the product line did not have to be redesigned. In coronaries, for example, when you move from femoral access to a radial access, you could still use the same products on the shelf. You never needed a new product. That is why the adoption of radial access for coronary was very easy. Problem with peripheral intervention is the entire product line has to be redesigned. You need to have longer sheets, you need to have longer balloons, you need to have crossing catheters, and there is a certain lag time for the industry to catch up with all these products. And by the time all these products are available, that's the time when radial access would be prime time. So yes, we know from our experience that radial access is safer, but we also need all those tools available to us. Now, having said that, what are we really missing? I think we have done a great job with the sheets that we have. We have sheets that are 6 French, we have sheets that are 5 French. So we can go into tiny radial arteries as small as 1.8 or 1.9 millimeters. What is very, very important to mention in this case is those balloons. So the balloons as long as 230, 250 centimeters are available that could go all the way from your radial axis down to the pedal axis and come back up along the pedal loop.
Okay.
That has been very instrumental. We have 6 French stents that are available that could be inserted. The problem is we're missing some tools. And now mentioning that, we don't have a longer IVUS. We don't have a long laser atherectomy, which is 200 centimeters or longer, which is RX platform. So we really need to do that. We do have a 200 centimeter plus or 220 centimeter plus over the wire, but an RX is still missing. We don't have drug-eluting stents that could be delivered all the way radially down, so 200 centimeters long. And I think there is also a part of a problem is we don't have covered stents that could be radially delivered. So yes.
So a lot of room to expand here.
Short answer for your
for industry. It sounds like we have a lot of work to do at SurModics. So yeah,
yes.
that's exciting. What is some of the feedback you get from your patients that have done a radial procedure?
So patient satisfaction is paramount, and they are really happy. A lot of my patients who have peripheral arterial disease also have bad common femoral arteries, due to which access and closure is a problem, and sometimes they have to lie down for 4 to 5 hours post-procedure. So radial access is completely eliminated there. I can get these people out of my cath lab in 45 minutes to almost an hour. So patient comfort is great. Patient safety is there because you are not at risk of developing any large retroperitoneal hematomas. So we haven't seen that. So I think whichever way you look at it, it's worked out great for us.
Okay. Thank you. Well, that's all the questions I have today. Thanks for joining us at the TED conference, and look forward to working with you again.
Thank you so much.
Thank you. Bye.
You have to do that again, or? Let's just do the second.
Sorry, my alarm was going off. That was the 5-minute alarm. I was like, oh, shoot.
Let's do the last part again?
Yeah, made the last part.
Yeah.
So we'll start with a question about the radial for the patients, and we'll do that, yeah. So Dr. Lodha, What is the reaction you get from your patients after they have a radial procedure? What's their experience?
Yeah, patient satisfaction has been great. Most of my patients have peripheral arterial disease, have diseased common femoral arteries, and access and closure is a big problem. So they have been post-procedure have to lie down for 4 to 5 hours of bed rest, which is very uncomfortable for a lot of them because they also have concomitant back problems. So radial access has completely eliminated it. I can get these people out of my lab in 45 minutes to an hour. Actually, post-procedure, we don't even keep them lying down. We actually have them sitting in a reclining chair, and they do perfectly fine in those cases. So I think when it comes to patient safety, patient satisfaction, it is doing well. We cannot overemphasize the fact that there's no incidence of retroperitoneal hematoma in these cases, so vascular complications are really minimal with radial access.
Well, I'm very excited to see the new technology coming out. It sounds like radial procedures are great for the patient. And I look forward to working with you again. Thank you.
Thank you so much.
Yep.